the Darlington Way for the QI project, which started back in January 2020. My name is Sarah Goodwin. I'm the lead paediatric diabetes dietitian at Hull University Teaching Hospital, and I was nominated by my team to be the QI clinical champion. And today I'm going to look at overcoming challenges and barriers that we as a team faced during our QI project. A bit of background about the project. So our aim of the project was to reduce the median HbA1c of our cohort by improving self-management skills of our children and young people. Our objectives was to try and get all our patients to home upload their devices, to get all of our patients to then review data and adjust management, and for all newly diagnosed patients to start carbohydrate counting from diagnosis. A bit of background about our area in Hull University Teaching Hospitals. So as you can see from this graph, we are this blue little diamond here, and our HbA1c was above the national average. So this is something as a team we really wanted to work on and thought it was a perfect opportunity as part of our QI project to have our aim is in reducing the mean of our cohort. We also wanted to look at teaching our newly diagnosed patients to carbohydrate count from diagnosis, as this data shows that only 30% of our patients previously were taught a carbohydrate count within the recommended 14 days of diagnosis. What used to happen with our patients is they came into our ward, they were commenced on fixed doses of insulin, and dietetic support was given where able, and it was endeavoured to be within 2 weeks of starting carbohydrate counting, but in over 2/3 of patients that didn't happen. So this is something as a team we really wanted to focus on. A bit of background in terms of timelines at our projects, because as Matt pointed out, the timings were a little bit different from usual. So if we look at the top arrows, which is just the timeline of our project. Our project started in January 2020, where we went for our first face-to-face meeting as a full diabetes team to Darlington. We then started implementing part of our project in the February of 2020. However, in the March of 2020, the pandemic hit, and as dietitians in the team, we were redeployed to other clinical areas. As I was the QI clinical champion, the QI meetings were halted for a period of time as everyone dealt with other priorities. In June of 2020, we returned to paediatrics and were able to restart some of our QI meetings. However, they were virtually. In September, we refocused on our patients uploading. In March, the official wave of our QI project ended, and then we'll look at currently where we are with things. In terms of teaching the carbohydrate counting on diagnosis, as you can see, this actually started slightly earlier than the project. From the previous graph, we knew that this is something that we really needed to focus on, and the idea for starting to teach carbohydrate counting whilst the patients were on the ward, so their first subcutaneous injection was a carbohydrate counted injection, and started back in August 2019. We needed the whole team to be able to buy into the project, and hence we thought it was a really, really good idea to focus on it as our QI project. In the background prior to this, the dietetic team had done some training of the ward staff. So all of our nursing staff on the ward are able to carbohydrate count. We set up some dietetic lesson plans for teaching this and also for teaching our patients on the ward. So we had some consistency. We did some development of the resources is in December 2019, and we carbohydrate counted our full paediatric hospital ward menu. I say full ward menu, however, there's possibly less than 100 items on the menu. So compared to some of larger hospitals that have multiple paediatric menus, our menu is quite small and discreet, so it wasn't too onerous of a task. Then, in line with the project, we rolled out our carbohydrate counting on diagnosis on the ward in February 2020. Alongside this, we also developed a bit of a photographic reference table for the ward menu, which had been carbohydrate counted, because we realised that some of our nurses needed a visual guide as they were visual learners. Also, that sometimes the family needed to look at how much was going to be portioned out beforehand to work with the nurses to then carbohydrate count. Alongside the national timeline, it actually worked out really, really well that in February 2020 we started implementing the carbohydrate counting on diagnosis, because all of our outpatient appointments were stopped from March 2020, all of our face-to-face appointments. So therefore, we would not have been able to call newly diagnosed patients back to the hospitals to teach. So it was fortunate that we're able to teach them whilst they were on the ward as an inpatient. The project went through the whole year and is still continuing at the moment. And then in January 2021, we started looking that we need to do some refresher training for our ward staff. We've had to look at a revised dietetic timetable to make sure that there's always ward cover and a bit of a backup plan. In terms of our second arm of the project, looking at patients uploading their blood glucose devices at home, we identified in January 2020 the number of patients that had the capacity to currently upload their devices at home. We looked at producing resources and guides for staff as well as patients on how they could do this. In March 2020, we communicated with all our patients on the cohort or that we wish them to start doing this via our team newsletter, which went as a printed copy, and we also sent it out on Digibet. In September 2020, we realised that lots of patients had started uploading, but we still had a minority of patients who weren't. So we did an individualised approach where these families were contacted by various members of the team and asked what their reasons were for why they couldn't upload. And then from January 2021, we started looking at our next steps for the project as to how we could get these patients to actually make some self-management changes once they were uploading. As I'm sure other teams will hear, lots of our families upload their devices and say, I have uploaded for you. And we want our families to change that mindset and to have uploaded their devices so they can review themselves and do some self-management changes, contacting the team if they require support. Some stats from our project. So when we looked at the reasons why some of our patients and families were unable to upload their devices from home, we had 56 of a cohort of approximately 250 that weren't able to upload. Some of it was the technology. So actually the mechanics of how to use it and how to do the uploading. Some of our families didn't have access to computers. Some of our families were actually weren't able to get hold of. So we telephoned around families and we couldn't get any contact from them. Some families were very honest and said they didn't actually have any reason why they couldn't do it. Or some said, I have no time. We had some patients that claimed that they didn't have any devices. We had a number of patients, two patients that were on the Accu-Chek Solo pumps and they were unable to actually download that. We had some patients that English wasn't their first language and that was one of the reasons. And we had some patients that said they'd never been invited to upload from home. So we as a team, we looked at all of these reasons and then individualized each approach as to how we could get around this. Our patients that hadn't been invited, we made sure that they had the details, our clinic access codes in order to be able to do this. Our patients that English wasn't their first language, we were able to translate our information. One family needed it in Polish, one family needed it in Latvian. So then they had written instructions on how to do it. Our patients that we were unable to contact, we envisaged trying to keep contacting them. We sent them letters, as it could have been that our telephone numbers for these patients were incorrect. And we also implemented that each time one of our patients comes to clinic, uploading is discussed at every single clinic appointment. As you can see from the graph on the right, you can see that our number of patients who are able to upload at home slowly increased across this time period. And by January 2021, we're at 88% of our patients that now had the ability to upload at home. In terms of carbohydrate counting on diagnosis, I'm pleased to say that from February 2020, when we implemented our project, and our first patient was actually diagnosed on the 5th of February 2020, he, who started on the new pathway of carbohydrate counting on diagnosis. And actually, until present date, 100% of our newly diagnosed patients have been taught to carbohydrate count on diagnosis. And I have just been this morning to see a newly diagnosed patient to start them on carbohydrate counting. Interestingly, our numbers of newly diagnosed patients has significantly increased over the last 18 months. And I think from April 21 to present, we are already at approximately 30 newly diagnosed patients this year. And there's still sort of 5 months left of the year. So this is higher than average for ourselves as a clinical team, as we possibly only get normally 20 to 30 newly diagnosed patients each year. So as we come to barriers, we can see that this is something, another challenge that we needed to overcome. I'm also pleased to show that through our QI project, our clinic median actually did manage to reduce. Our median in January 2020 was 66, and in January 2021 it was 65 millimoles per mole. So still not in that ideal category where I would like to be. However, we did show through these projects we're able to reduce our clinic median. Some of our achievements that we managed throughout this project, we realised that as we were no longer able to have face-to-face appointments, we did them virtually with our teams, our patients, but we couldn't get some of our anthropometric measurements from them, and we also couldn't get HbA1cs. So the team rolled out a postal HbA1c service where we sent kits out to our families, and they were able to take capillary bloods from the patient and post them back to our labs, which processed them. And we managed to send these out to no, we sent them out to more patients, but we managed to receive back 105 HbA1cs for our families. We managed to set up a team WhatsApp group. We managed to have staff having access to all electronic platforms. We were fortunate enough that Digibeat was launched and we had access for our patients during this time period, and we managed to get 116 of our patients, so that's nearly half of our cohort, 46% signed up for Digibeat. 45 of our patients, 19% if our patients now have an HbA1c under 53 millimoles per mole, which is a huge improvement from our 2017-2018 data, where only 9% of our patients had an HbA1c under 53 millimoles per mole. During this time period, despite our dietitians being redeployed to another service, we actually managed to have 184 of our patients have an individual dietetic appointments. We achieved this by setting up dietetic video clinics, and we've had a positive Prem report, which was higher than national and regional averages from our patients. If we then look at some of our barriers that we faced over this time period, I just wanted to point out that our team had some big change in dynamics. And also the pictures show the way the world changed over that period of time. So in January 2020 is a team, the top pictures actually when we did come to Darlington, and this was in the foyer of the rugby ground, the conference centre that we first met Matt and Trish. And you can see that we're a team, we're all bunched together nice and closely. Whereas in January 2021, they did have a team timeout day, and we all have our face masks on. We are all socially distanced, and I'm actually only on that photo via laptop because I was self isolating at the time. So we have adapted things. So the team met face to face. I was having to self isolate. So the team set up a web link for the meeting, and I was on the photo via the laptop. In terms of the project, because of all the changes we've had in our team, this I feel is one of our first barriers to the project. We've had a changing and evolving team, and this has required that we've had to have buy-in from new team members about the project, and we've had to recap the project on numbers of occasions. So you can go through the process of change with a team, and you can have a foreman, storeman, and Norman team. And our team is still in that foreman phase. So we do have some core members that have stayed with us throughout the project, myself being one. However, we've had some various changes. We've had additional consultants join the team. We've had lead nurses leave the team. We've had other nurses join the team. We've had a change in dietitians. We've had a change in our data quality officer. And we've had both of our psychologists have changed as well. In terms of what other barriers we faced during this time period, so I suppose the big one would have been for all teams at this wave of QI projects with all our COVID related issues in terms of redeployment of staff, social distancing, the change of the way we work. Our solution, we did the best with what we had and we learned to adapt our ways of working accordingly. Another one of our barriers, this was before the pandemic started, we realised that as a team, quite a large team, but we weren't very effective at our team communication. So whilst we're in Darlington, we actually had heard from some other teams that they had a team WhatsApp group as a way of fast communication, certainly for when newly diagnosed patients were admitted to our ward, and we felt as a team this would be a really great idea to implement. However, that was a barrier in itself. We had some earlier adopters of this as team members that already had smartphones, were familiar with using WhatsApp, set up the group straight away. We had some reluctant team members that didn't really want to do this, didn't feel technology was their thing. So we had to get their buy-in to the project because it wasn't going to work if all team members weren't on the WhatsApp group because we'd still have that communication barrier. Then we also had some technical issues that some of our team members, our lead consultant actually, his work phone wasn't a smartphone. So he wasn't able to do this. So he was there, he was tech savvy. His personal mobile was on WhatsApp. However, his work phone wasn't. And in terms of information governance, and it was felt that it all should be on our work mobile phones. We don't share any patient information. We just have a process that, so yesterday I found out we had a newly diagnosed 4-year-old on the ward. So I knew instantly that today, my first day back at work, and unfortunately we had no dietitian on site yesterday, that I would need to arrange to see that patient. So a much, much faster way of doing things. One of our next barriers was team engagement. So getting everybody involved with the project and to be able to join in with things. We had some core team members that were really, really keen to get going, and some others who, quite despite all the stats, didn't see the significance or didn't know how they would be able to fit it in to their routine work. So what we did is we picked the projects, we started small scale, and then and with the momentum, our other team members could see the benefits and joined along. Another barrier that we highlighted was that the lack of face-to-face QI meetings means we felt it was a missed opportunity for network and mutual learning. However, we've had to adapt to this because this is the way the world is, and this is the same as your cohort of QI projects. So we've adapted that to the best we could. We have, when we've been on our working groups, we've connected with our other colleagues and we've then set up email groups. Or I've been in contact with other dietitians from the Darlington Wave for a bit of peer support and networking opportunity like that. A barrier as a team was the fact that we're unable to meet face to face for our QI meetings that we were setting up because of social distancing. We didn't have a room that was large enough, and also some of our team members were working from home, so therefore they wouldn't been able to join. We've adapted to this by changing our meetings to virtual meetings so that individuals could join from any location. And that picture at the bottom of the screen again is where we were having one of our QI meetings and we had team members in all different places, which actually has worked really well because there's been times where somebody was maybe he's on a visit and they wouldn't have been back in time for the meeting, but by having the meeting virtually, they were able to access because they didn't have the meeting time to include in that. But that with itself, setting up those virtual meetings was a bit of a challenge because all of our team didn't have access to technology. So some of our team members didn't have webcams, some didn't have headsets, some didn't have microphones. So I don't know if you all want to cast your minds back to sort of the early starts of the pandemic when you may have all been joining virtual clinics and meetings yourself. And if you're in a meeting and you haven't got a microphone, so the ability to speak and communicate, whereas everybody else in your meeting has, that's then very different and very frustrating for team members. So we've overcame that. Our trust was very, very good in being able to provide us with the equipment. When equipment was available, there was a time where there just wasn't any webcams to be able to purchase. And the same in terms of our team members who didn't have access to the right work phones. We didn't have any problems with finances or our senior managers signing off that phones could be upgraded. Another barrier we faced was whilst in MDT clinics, we run our clinics that a number of team members sit together and see our patients when we see them face to face. We wanted to keep this clinic set up replicated when we converted our clinics to telephone clinics. However, some of the phones in our consultation rooms didn't have speakerphones on them, and also the sound quality was very poor. And we were concerned then as a clinical team that we were unable to social distance whilst trying to speak across to our telephone. We asked if we could have dedicated conference phones for the rooms where we run our MDT clinics, and we have a very, very good now conference phone that we can put in the middle of the room. Team members can sit socially distanced and can hear our patients very, very clearly, and our patients can hear us. We don't need to shout to the telephone. As I've already said, doing telephone clinics meant we weren't able to take HbA1cs from our patients, and our solution to this was setting up a postal HbA1c. We've now recently also set up a drive-through HbA1c for some of our families. However, this is still a barrier for some families if they don't have transportation. In terms of our barriers to technology, the first barrier we found was that some of our team members didn't have access to all the platforms themselves. And we very much felt that as a clinical team, we couldn't be asking our patients to do something that we couldn't do ourselves. So this then required staff members to all have their own individual logins to a number of platforms, Diasend, Dexcom Clarity, LibreView, CareLinks, Twinkle, WhatsApp. Some team members then didn't know how to use these platforms, so we developed team staff members as how-to guides for how to upload the devices from clinic and from at home and how to view them. We then also did this for our patients as well. So we looked at communicating to our patients via the newsletter of how to upload, sending out all our clinic codes and step-by-step instructions. We translated these into different languages when required. We needed to also look at our terminology when we were talking about our technology. As previously as a team, we talked about downloading. Have you downloaded your device? However, then it was pointed out by some team members, actually, when you go to the platform, when you go to Leave Review, it says upload. So if you weren't very technology savvy, you'd think, well, I can't do what the team's asking because I can't download because there's not a button option to press. So we need to be very mindful about the wording and the language we use. For our patients that were identified that they didn't have access to the appropriate technology, so we found that lots of patients might have had tablets or mobile phones, so they had internet access. However, the meters that we're using were predominantly used the Accucheck Expert meter. You need a USB connection on your computer, so it requires you to have a actual computer, a desktop or a laptop with a USB facilities in order to be able to upload your meter. And lots of our patients didn't have this. As schools were closed during this time period, we were unable to use one of our default strategies, which was going to be ask the family to contact their school and see if they could do it in school, because our schools have laptops and computers, and in the past we'd had lots of schools very on board with this, but schools were closed. So we then looked at as a team, actually the expert meter was going to be getting phased out and rolled out regardless. So if those meters broke, there wasn't going to be anything for our patients to move on to and use. So we looked at moving our patients across to the Unio meter using the My Life app, and then that if you use it on your mobile phone, uploads directly to DiaSend. So we found that that really significantly helped because then actually our families didn't have to do it. It was automatically done once that initial setup was done. We also found across this time period that we had more and more patients that were eligible for Libre and wanted to move on to the Libre. So our Libre usage increased, and this helped with our number of patients that were uploading. Some of our families still struggled with this, and we are constantly encourage them in clinic of the benefits, of the reasons why we would want them to do this. In terms of carbohydrate counting on diagnosis, is one of our barriers was that the dietitians were redeployed from the service to work in adult services, is so the numbers were down. Fortunately, during this time period, we had a low incidence of newly diagnosed patients during the time that the dietitians were redeployed. However, our solution to the problem was that any newly diagnosed diabetes patients was given the highest clinical priority across all our paediatric dietitians, and any of our paediatric dietitians who've been trained in diabetes would have saw one of our newly diagnosed patients if there wasn't one of our specialist diabetes dietitians available. Fortunately, we didn't need to fall back on this, but that was there in the background. One of our barriers was the resources that we'd usually use on the ward. We'd usually take numbers of food models and food labels to the ward, obviously because of COVID restrictions, and this was limited. So then we then set up some PowerPoint teaching presentations that we would take onto the ward with our laptops, because laptops can be very quickly and easily cleaned, because we felt that our patients still needed some visual aids to go alongside our teaching, and it helps with that consistency of our teaching. These PowerPoints came in very useful because we've had time periods where the only dietitian who was working that week then was having to self-isolate, and we had newly diagnosed patients on the ward. So the barrier to come around this, the solution to come around this barrier was we set up some virtual teaching sessions. So our patient was on the hospital ward, and our ward nurse sat the patient down with their family with a laptop or the ward iPad with a video link, and we did our teaching sessions virtually. So they had all the same education, it just wasn't face to face, but they were on the ward. And this actually worked really, really well. And I think for two patients, we've had to do it in this new way of working. Another barrier was the cancellation of our outpatient face-to-face clinics, and we've got around this as by a dietetic service. We actually use the NHS Attend Anywhere for our dietetic clinics. The MDT team run telephone clinics for their consultations, but for our individual dietetic clinics, we run the Attend Anywhere, which we find very, very useful as we can see our patients. And a lot of our work is behavioural change or education, and we very much want to see our patients' facial reactions. So it helps that they're not face to face, they don't have a face mask on, so we can actually see if they're smiling or gritting their teeth. But compared to a telephone, we can also see if they're rolling their eyes or if they've not heard us. So we find these virtual clinics very, very useful. What have we learned from our project? The first thing we've learned is sometimes we have to be detectives. All these technology issues is sometimes it's just the right button hasn't been pressed in the right order. Sometimes we feel that our patients feel we've got a magic wand, and that's not always possible. We've learned that actually we've got excellent communication skills with a team, and we can adapt to different communication styles. We have to be investigators to find out exactly where the error's gone with the uploading. We have to be IT technicians. We're now a very technology focused team. The biggest thing we've learned is that we need to start small and build on our successes. And even though we've been a very, very emergent team, changes of team personnel, that we actually are a team. And we've survived one of the toughest years, but we've still achieved as a team. Our next steps for the team. So I've talked about terminology, and my presentation has still got the wrong terminology. I do apologise. So this should say patients uploading. So I actually need to look at ordering the number of patients who regularly upload. So rather than those who have the capacity to do it, are they doing it regularly? And from those patients who do it, are they acting on the results? Are they making some changes? We've identified as a team that some of our patients need more empowerment to make those dose adjustments and changes. So look at how we can do some coaching, some education sessions for our patients, and perhaps producing some resources for patients to help them be able to dose adjust. I saw one of our patients on Friday who's been diagnosed for 10 years, our patient 16, and patient and mum both admitted actually they don't know how to change the carbohydrate ratios because they know they need more insulin, but they struggle with the math skill of does that mean the ratio goes up or does the ratio go down? So again, it's working on that individual level. They knew when they needed more insulin, they just didn't have all the skills to be able to work out how they adjusted their doses. So this is something we need to look at as a team. We need to look at having some team goals for consistency. We're looking at having more of the pump pathway, and we've recently process mapped our pump pathway with the help of our hospital health improvement team. And we're looking at our high HbA1c pathway and policy and re-implementing these.